Assalamu alaikum wa rahmatullahi wa barakatuh. Guys, can we start? Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Dr. Shoaib Wadi. Unfortunately, my screen is off because I'm still in transit on my way home. So I'm a bit in the dark here, as I'm sure many of you are around the country. I'd like to welcome one and all to this webinar hosted by the Islamic Medical Association. This is one of a series of webinars which we plan to have over the course of the year, touching on different topics. Today's topic is concentrating on ADHD, known as Attention Deficit Hyperactivity Disorder. And as way of introduction, we know that the ability to hold one's attention and to concentrate is essential for human interactions and for learning and for our engagement with each other. In fact, in Islam and within our culture, we understand that concentration is really important in terms of our day-to-day practice of Islam. Our ability to hold our attention during our salah, for example, is critical to achieving sukoon and goodness in salah and to fulfilling the intention that we make when we perform salah. Similarly, when we speaking to other people, our giving them our full and undivided attention is a great sunnah of our Prophet ﷺ, where he would turn his whole body towards another person and give them his full and undivided attention, so that they understood at that moment that they were the most important thing that he was dealing with, and they felt that. So obviously, if one is unable to do that for various reasons, it becomes pathological and can seriously impact on one's life. And certainly within our current social circumstances, we find ourselves dealing with major distractions at every single moment. Our lives are occupied with intrusive distractions, particularly with electronics and social media, and sometimes we make ourselves victims of this type of attention deficit. So that's an acquired form of attention deficit, but I think we're going to be concentrating on the pathological forms of attention deficit, and I'd like to introduce our first speaker. So before I get to that, just a reminder to all our listeners that please try and keep your video and your sound off. It can be very distracting to other participants in the meeting. Also, obviously, if you have low bandwidth, it can affect your ability to hear and to engage within the meeting. Secondly, we will be taking questions after each speaker. I would encourage you to put your questions in the chat box. There are a few of us who have been delegated as admins, so we will try and do that cooperatively, because as you know, with the vagaries of load shedding and signal, sometimes you get cut off, and if you do get cut off, you lose what's in the chat box. So we will encourage you to put questions in the chat box, but also to be patient with us if we're unable to get to your question. So our first speaker is, and I'd like to welcome Dr. Shakir Saldukar. Dr. Saldukar is a psychiatrist in a private practice in KwaZulu-Natal, particularly at the St. Augustine's Hospital. He's the director of the Durban Pain Clinic at St. Augustine's and the director of Psych Management Group of South Africa. He's a graduate of the Nelson Mandela School of Medicine and specialized in SA, and his special interest is in chronic pain management and opioids, anxiety disorders, and psychopharmacology. In addition, he started the first transcranial magnetic stimulation practice in South Africa, and he's a medical advisor to CIPLA South Africa. He sits on multiple medical advisory boards, and we welcome him to give his talk today. Assalamu alaikum and welcome, Dr. Saldukar.
Wa alaikum salam. Thank you for that introduction, and thank you for inviting me this evening. Assalamu alaikum wa rahmatullahi wa barakatuh to all the attendees. I hope we're going to be able to cover a lot of what is quite an important topic and difficult to cover in one talk, but I'll try as much as I can. I just want to start by saying that as a psychiatrist, we are often surprised and alarmed at the number of adults that we're seeing with ADHD that was not picked up when they were children. And so the onus then becomes upon us to spread the word and educate practitioners and people involved in healthcare about this condition. So I hope that there are multiple people out there who will learn and be able to pick up and diagnose this condition earlier on, because as you will see later in the talk, the outcomes of not doing it are actually quite catastrophic. So let me get started. Bismillahirrahmanirrahim. The topic today is attention deficit hyperactivity disorder. This is a disclaimer from the company that has asked me to do the presentation. So I want to start by just giving you a sort of comprehensive definition of what ADHD is. It's a highly heritable disorder of the brain, which is thought to be a dysregulation of dopamine and norepinephrine or noradrenaline, and their associated neural pathways, resulting in impairment of cognition, emotional regulation, and behavior. It's quite a mouthful, and I don't expect that you need to remember all of that. Suffice to say that it's not just about school and learning, but has quite a broad range of effect and symptomatology and consequence. The three dimensions of attention deficit hyperactivity disorder is inattention or impaired concentration, hyperactivity or inner restlessness, and impulsivity. These three are manifest in many different ways depending on what stage the person presents with, and we'll come back to that in a second. So let me start off by asking the question, does anyone have perfect concentration? Does anyone have the ability to sit for a period of a few hours and focus and concentrate and absorb absolutely 100% of everything that they're reading or looking at or trying to absorb? Obviously not. Can anyone sit absolutely still for an indefinite period of time? Also not possible, as we know. Is everyone capable of having absolute control over the impulses? I'm pretty sure the answer to that from all of you is also no. So does that mean we all have ADHD? No, we don't. We don't have the disorder, ADHD. The D at the end stands for disorder. But we all have a degree of its symptoms or domains, meaning none of us have perfect concentration. We all have a degree of restlessness, whether it's internal or external, and we all have a certain amount of problems controlling our impulses. So what does that mean in terms of understanding ADHD? What that means is these conditions or this condition and the symptoms that it presents with exist on a spectrum, and there are many things that determine what is sufficient for treatment and what needs to be left alone. And that's the nuanced definition of treatment. Where do we intervene at what point? It also has implications for many other things. The fact that we all have some degree of inattention, that we have some degree of restlessness, means that pretty much every single human being, if they take a tablet for ADHD, like Ritalin, for example, will have some degree of improvement in concentration, will feel subjectively like they're more focused. And that speaks to a different topic altogether, which is probably a talk all on its own, which is cosmetic neurology, which is something that's happening all over the world and is a hot debate between the different sides of medicine and people that feel that we over-medicate. What is cosmetic neurology? Cosmetic neurology is the use of pharmacological agents to improve normal function. So if you take something, for example, like Ritalin, and you are writing an exam or doing a PhD dissertation, or people on the stock market, for example, which is quite common, they don't have the disorder, but they have the normal human degree of deficiencies in attention, and it gives them the slight edge. Now, I'm pretty sure all of the doctors out there have had patients coming to them and saying, "Doc, I'm writing an exam, I need to study, or I've got, to finish my dissertation, I need to be able to sit for longer than 1 or 2 hours. Please give me some Ritalin, please give me some, medication to help me." The debate is ongoing from several perspectives, and we don't have time to talk about that. Suffice to say that there is a kind of split opinion on that, because the first rule of medicine is obviously first do no harm. So the question is, does this actually do any harm to the person that's taking it ad hoc or on a PRN basis? And the answer to that usually is no, unless they have some other psychiatric condition or other disorder where they react to the medication. So I think it's important to understand that just because someone is taking Ritalin or taking treatment doesn't mean they have ADHD. The other thing to bear in mind with ADHD is that it's got quite a checkered history. People have believed for many years, decades, that it's a disorder of childhood, you outgrow it. As soon as the day you leave school, you finish your last matric exam, the ADHD is gone, and then your life begins. It only exists during school hours, and unfortunately, this is still a belief system currently because a lot of specialists, in fact, not just general practitioners, but specialists who treat children with ADHD only treat them for that duration that they are in school between 8 o'clock and say 1 or 2 o'clock in the afternoon, implying that attention, concentration span, the inability to sit still only affects your ability to learn at school. Whereas unfortunately, that is just one very small part of learning. As Shoaib mentioned earlier, there are many other aspects to concentration and learning. And in people or children in particular that have this condition, it affects just about every aspect of their learning. There are social learnings, there are interpersonal learnings, there are day-to-day activities of daily living learnings, how to cross the road, how to interact with people in a shop, for example, how to be able to operate certain appliances in the home. All of these require concentration, and you must understand that the sequence of events is attention, concentration, short-term memory, long-term memory, and then learning. So if you don't have attention and concentration, you're not going to get the working memory, long-term memory, and learning happening. So learning is an all-encompassing thing that happens throughout our waking hours. So please remember, this is a critical point about ADHD. It's not there only during school hours. It is there 24/7, 365. This concept of outgrowing it, that they're just naughty children, is actually terrible, because once you apply that kind of approach to these kids, they miss that window of opportunity, and the treatment early on is critical because of the concept of brain development. Most of the brain development occurs early on in life. The earlier you can modify the way a brain is developing, the more profound the long-term impact of that intervention is going to be. So there's a lot of reticence amongst doctors and parents particularly to putting kids on treatment if they have ADHD. But once you leave it beyond the senior primary level, the kids have already lost the basics of their comprehension, numeracy, and literacy, and they're always going to be struggling. So it's really critical to diagnose early and start treatment early. There's also this sense that there's an overdiagnosis by the profession, and all kids are just put on treatment because it makes the teacher's life easy. It's a plot by the pharmaceutical company to sell their drugs, and they kind of get people to convince you to put people on medication. Then there's a Church of Scientology, which kind of does the opposite of everything that's scientific. And that's one of the conditions they've targeted in their tirade against medicine, is the fact that we are creating zombies by putting children on ADHD. So all of these things have existed and have been a roadblock to early intervention and treatment. And even though we're getting better, these things still exist, unfortunately. And it's something that we need to address through education, through spreading of facts and science. The reality is it is a real disorder. It exists on a spectrum of severity and a dominance of symptoms domains, which we'll come back to. It is biologically visible. There are multiple neuroimaging studies available on the net. The one thing I want to say to you during this talk is I'm going to be touching on broad points, the details of which, if you're really interested in, you can contact me. But we live in an age of information, or we've passed the age of information, where anything you want to know, you can just get within a matter of milliseconds by going online and searching for it. We are now in the age of wisdom. And what that means is we have to take all this information that's easily accessible and kind of make sense of it and apply it to the real world. So I'm going to be just touching on the larger sort of outcomes of the multiple studies. And ADHD is a hugely studied condition, lots of neuroimaging studies, lots of neurocircuits that have been identified, neurochemicals, and all of the data is there if you want to look at it. It has a statistically significant improvement with treatment. In fact, in correctly diagnosed and correctly prescribed cases, one of the most significant improvements in psychiatry or brain disorders. It has a very clear genetic roadmap. It is one of those conditions that is almost 80% plus heritable. So it's almost guaranteed that if one parent has ADHD, the likelihood of one of the children having it is high. And there have been major advances in the last 2 to 3 decades in its understanding and, of course, consequently, its management. The incidence generally, and I think this is probably a little bit dated, and I think as the diagnosis and awareness increases, so the incidence will, but it's worldwide regarded as almost 10%. So 1 in 10 children will have some degree of ADHD, and 3% of adults worldwide, and we'll come back to that conversion a bit later. 45 to 60% of the children with ADHD progress to adult ADHD. And remember, when we say ADHD, we're talking about the disorder. So there are many children with ADHD that progress to adults with symptoms of ADHD, but not necessarily the full disorder. Then the increase in diagnosis in recent years, as I said, is due not to the fact that we've been punted by pharmaceutical companies to sell their drugs, but the fact that the awareness of the condition has increased. This is just a quick indication of the current position in the US, when the age of early diagnosis is 3 to 6 years, and about 6.1% of American children are being treated for ADHD with medication. So let's just talk a little bit about what the different subtypes of ADHD are. There's the predominantly inattentive subtype, there's the predominantly hyperactive subtype, and then there's the mixed one, which has inattention and hyperactivity, which is the most common one. So what do we see clinically in these cases? I'm going to broadly touch on the clinical symptoms and then try and specify how it's different in adults and how it's different in children. But in general, they all have a short attention span, which translates to an inability to focus and concentrate for long periods. They tend to get bored easily, they're easily distracted, they zone out, they daydream. Clinically, in terms of the hyperactivity, there's a sense of restlessness, inability to sit still, fidgetiness. They tend to be a bit clumsy because of the motor control. They're also quite loud and noisy. They have low muscle tone. They tend to be a bit floppy. They have bad posture. And as a result, they have poor handwriting, also because they're rushing. A child with ADHD and an adult with ADHD is characterized by a brain that's moving faster than the normal brain. And as a result, everything happens at a faster pace. The impulsivity is what leads to children blurting out in class, being impatient, acting before they're thinking, and making bad decisions as they become adolescents and young adults in terms of substance use. Because of the impulsivity, they're more likely to try things, they're more likely to experiment and give in to peer pressure. Risky behavior is common, often getting into physical fights because of their poor impulsivity and the fact that they tend to act before they think or speak before they think, and as a result, they are unable to control their urges or the impulses. There's also the concept of sleep phase delay, which is a problem from childhood and tends to settle as they grow older. Sleep phase delay means that these are children who struggle to fall off to sleep and then struggle to wake up. So the entire circadian rhythm shifts towards later in the evening. They're often anxious or aggressive. Males or anxious tend to be a bit aggressive. They speak faster, think faster. They struggle to complete tasks. They struggle with timekeeping. They're often the last-minute.com studiers. They're the ones who leave everything to the last week, and then they panic and they try and get in and cram as much as they do. And there's the concept of hyperfocus, which is an important thing to bear in mind, because parents will often bring a child to you and say, this kid's not concentrating and he's getting into trouble at school, but put him in front of the PlayStation and he can sit there for 4 hours and 5 hours and focus to the point of being completely zoned out from everything else and just focused on the PlayStation. Hyperfocus is actually part of the ADHD syndrome. And if it's something they like or passionate about, then they can hyperfocus. It doesn't mean they don't have the disorder. It just means that they are shifting. Again, clinically, the hyperactive subtype is thought to be more prevalent in boys than girls, and the inattentive subtype more prevalent in girls than boys. And this is the reason why a lot of ADHD is missed in girls, because they're quiet, they sit quietly in the class, but they struggle academically. And herein lies the real tragedy of not being diagnosed. A lot of these kids have a normal intellectual quotient or intellectual capacity, sometimes even above normal, but they're unable to translate that because they're unable to focus for long periods. So the hyperactive subtype is much easier to diagnose. Most people will be able to tell within the first 10 minutes that this is ADHD because it's so obvious. The inattentive one is the one that we need to worry about, and it's the one that's, focuses on the child sitting still and being quiet and not speaking and not volunteering answers, but also struggling academically. Of course, what we see in clinical practice is the mixed type with both. Comorbidity in ADHD is the rule. This, if nothing else from today's talk, is something that we have to remember. Comorbidity means that there are conditions that exist together with ADHD, which are either masking or exacerbating the symptoms, and sometimes interfering with the treatment, and also masking the effect of treatment. And we'll talk a little bit about that in a bit. And it is the rule, and often a child who's diagnosed with ADHD the diagnosis is made, the prescription is given, and that's it. There's no further investigation or assessment. But that's when you don't get the most out of the treatment. And it's important to bear in mind that these children and adults have one or more comorbid condition that needs to be looked at. It's also important to understand clinically that the symptoms in ADHD evolve over time. So the younger kids start off with a particular cluster of symptoms. As they become adolescents and teenagers, it changes. As they become young adults, it changes. And as they become middle-aged, it changes. So just because these symptoms evolve as a result of the environment and the expectations, it doesn't mean that the condition has changed. It's just the way the brain is working has changed the way people are understanding and dealing with the environments. Typically, and should primarily be diagnosed in the early primary school phases, or the, between grade 0, 1, or 2, to get the ideal best outcome. Because as I said earlier, if you pick up the diagnosis early and you start treatment early, then the fundamental basis, or the fundamental basis of the rest of the education, which is numeracy, literacy, and comprehension, is the basics are put in place. Now, if they miss out on the basics early on, you can imagine that they're playing catch up, for the rest of their academic lives. And remember, most of the learning, it's a kind of an exponential curve in terms of learning, because the younger you are, the more your neural connections are forming, the faster they're forming. And as you grow older, it gets less and less and less until you reach an age of about 25, where the new neural connections don't form, but you get a development of the existing neural connection. So early, I think somebody has their microphone on. If you could just please switch it off. Thank you. So it's important to pick up this condition early on, because the human brain from birth to the first few years of life learns more than the person learns and absorbs for the rest of their lives, because of the rapid rate of neural connectivity and new neuronal cells forming. So it makes sense that if a problem is picked up early, and this doesn't just apply to ADHD, it applies to just about every neurodevelopmental problem or any condition of the brain. Earlier the diagnosis and intervention, the more profound the impact of the intervention. This is just a point I want to make in terms of probably something that you may not find in textbooks or if you Google it, but it's something that we see in practice a lot, is there's a link, or there's a there's a connection between intellectual capacity and the manifestation of ADHD. So kids who have a high intellectual capacity tend to slip through the net because it's easy for them. They pick it up early, they do well at school, the teachers don't complain about them, parents are happy because their report is okay. But once they climb up the ladder and they go to higher standards and higher grades, and the challenge becomes greater, and the challenge and the expectation of attention span and concentration increases, so that balance between intellect and concentration starts to normalize a bit more. And this is often a reason that a lot of kids present later on, perhaps in high school or senior primary, where they start to pick up symptoms where they're struggling, where they weren't struggling earlier on. So I think it's important to just bear in mind that if a kid is particularly of a high intellectual capacity, but has other symptoms of restlessness and hyperactivity and impulsivity and behavioral problems, but is doing well at school, is still somebody that needs to be assessed. They may not necessarily need treatment unless their behavior or other aspects of the condition are affecting their functioning, but it's good to pick up early on so one can monitor and see at what point they might need some intervention. This is also the concept that drives what we call functional ADHD, where often you find that kids and adults have all the symptoms of ADHD and it does not affect their functioning or quality of life. And this is where it's a very nuanced decision about treatment. It's a qualitative decision. So it's not one where you would follow a rating scale and say, yes, he has A, B, C, and D, therefore he must be on treatment. So because it exists on a spectrum and it's a complex, multidimensional spectrum, one has to look at all these things before deciding on or initiating treatment. So just a little kind of aside in terms of how it's slightly different in adults. So as I said earlier, 30 to 60% of kids who have ADHD progress into adulthood. They typically present to us in their 40s, and usually it's because they're depressed, they're anxious, or they're in a crisis that they come for help. And during that assessment, you know, once you take a history and you go back a little bit, you realize that this is a person that's been struggling with ADHD. Remember, 2 or 3 decades ago, ADHD wasn't commonly diagnosed in schools and by general practitioners or medical fraternity. Parents were not aware that it existed. Kids were often just seen as being slow at school or not academically minded or naughty or whatever. But that condition then goes on to, as I said earlier, interfere with the ability to learn social skills, the ability to learn, the basics of day-to-day living. And as a result, when they become adults, they are they're often in crisis. They have problems, multiple relationships, multiple jobs, unable to complete the tasks. They are chaotic in terms of their admin. Their taxes are, sort of in disarray. They'll tell you they can't read for long periods. They get bored easily. They often have little fender benders because they're always late. They have problems with timekeeping. So they're rushing around, and because of the impulsivity, they have road rage, impatient. As I said, they often start things and don't complete it. Problems with interpersonal communication, which affects their personal lives and their families, with their spouses, their children. They often also end up being adrenaline junkies. They do lots of risk-taking behavior. They would complain of an inner restlessness. So often when you see an adult who's got ADHD, they can sit still in your office during the assessment. But if you ask the question, do you often feel restless inside, or do you feel like, something, you need to be doing something? They will, answer in positive. They are also ideas people. So remember, because their brain works so quickly, they kind of think things, and it's often like a fleeting thing. And they have these ideas because the processing happens much faster. So in an ideal, and I've had many situations where adults with ADHD have kind of gravitated towards situations where they are in a job, where their job requires them to actually be innovators or ideas people, and then they are the more organized and structured people that work for them that implement those ideas. And that kind of works very well. They also have a high comorbidity of substance use disorders in the adults. They're often self-medicating with alcohol or cannabis, which is the big thing now. Cocaine is more common, and we'll come back to that in a second. So, in terms of that was a clinical presentation in children and adults. And again, as I said, I'm trying to cover quite a large amount of information. So there's a lot more to that. You know, if you really want to know, there's lots of information available. When it comes to diagnosis, just remember this. There are many people who have lots of fancy ideas about how ADHD can be diagnosed using neurofeedback, using EEGs, using certain tests, and what it is a clinical diagnosis. It's based on a good history, assessment. There are no biomarkers that one can rely on to tell you this is ADHD. So it's basically a detailed history, assessment of the individual, collateral information from home and school, and there are rating scales which one can use, like the Conners, the Van de Waal, and so on. But it is primarily a clinical diagnosis made in the office or at the bedside. The differential diagnosis, so children who have, or you think might have ADHD, remember they can also have conditions like conduct disorder or positional defiant disorder, where the behavior and the kind of trouble that they get into mimics a hyperactive child. They might have learning disabilities, which might mimic inattentive type of ADHD, where they struggle academically. Anxiety disorders, this is a common thing, and there have been a significant number of patients that I've seen in practice where they were just anxious kids who were diagnosed ADHD, put on treatment, which obviously makes the anxiety a lot worse, but they don't do well. Remember, anxious children purely, now I'm not talking about the comorbid anxious, but just anxious kids, are kids that are overthinking and worrying about things that are beyond what is their scope to worry about. So they would sit in a class and worry, you know, is my mom going to be coming to pick me up on time? I hope that, you know, the house doesn't get broken into, or my dad doesn't get hijacked. Or, you know, the kids that, these are sort of irrational thoughts, but that's what anxiety is. So if you take a child who's anxious and they're sitting in a class and they're worrying about all these things which are irrelevant to what the teacher's teaching them, it might come across that they have a problem with concentration. So I've seen this clinically many times in practice where anxious kids are misdiagnosed with ADHD. And then we have bipolar disorder in children. This is a concept that a lot of people struggle to accept, that bipolar disorder can exist in children. Bipolar disorder is a disorder of the brain. It starts from the day you're born if you're genetically predisposed, and it can manifest if there's an epigenetic factor that activates that gene. So we see multiple cases of different variations of bipolar disorder in children. And it can also look like hyperactivity, and problems with behavior at school can be misdiagnosed. Not as commonly as in adults, but something to bear in mind. There are other differential diagnoses which are more rare and so on, which we don't have time to go into today. In adults, we have the classic triad of adult ADHD, bipolar type 2 disorder, and borderline personality disorder, which all pretty much clinically come across in a very similar way, because the patients present with a very complex picture of cognitive problems, substance use, mood dysregulation, severe anxiety and agitation. And sometimes, even as psychiatrists, it's difficult to tease one out from the other. Also, again, anxiety and mood disorders can be a differential diagnosis for attention deficit in adults, as is substance use disorders. I mean, you know, the principle of diagnosis in any psychiatric disorder, when you look at all the criteria at the bottom, it says in the absence of a substance. So you cannot diagnose a person with any condition if they're using a substance until they've been detoxed of that substance and its effects. So coming to the comorbidity very quickly, the link to genetics is very important. It's a highly heritable condition. About 83% in the studies that have been done on genes. This is an important little party trick that you will be able to do in your practices. So if you see a child with ADHD, the likelihood that that child has got an anxiety component to his ADHD is pretty high for this reason. If you take a person who's got an adult who's got an undiagnosed ADHD, their lives are chaotic. They are disorganized. They're all over the place. They're adrenaline seeking. They're exciting. They kind of hop around. There's life and soul of everything. And then you have a person who's very organized, structured, perfectionistic, and they are, they kind of live vicariously through other people because they're afraid to do things. You have these two types of personalities that, by the laws of attraction, opposites attract, they're often drawn together. And the reason people tend to feel comfortable with a life partner is that they kind of fill the deficiencies. It's a subconscious process that happens. Nobody sits and thinks about it. It's just the way we are drawn to. So you often have an ADHD person, usually male, and you have a slightly anxious, perfectionistic, controlled, structured female, and they come together and they have a child. And this poor kid gets a bit of anxiety and gets a bit of ADHD, and you have comorbidity, anxiety, which I think is the commonest comorbidity in ADHD. And you often have to manage both. You can't just manage the one. Mood disorders are common, sometimes secondary, because remember, these kids are often picked on, they're often in trouble, they don't like going to school because they struggle, everyone else finds it easy, they find it difficult, so they can get depressed. And that depression has a profound impact on cognitive function. So it's important to also remember that ADHD in a depressed child could be more serious than just ADHD alone. And of course, substance use, as I mentioned earlier, can be a form of self-medication when they haven't been diagnosed. So it's all important to look out for these comorbidities. This is just a quick graphic to show that in children between the ages of 6 and 17, these are the common ones that were picked up in this study, which is learning disorders, sleep disorders, ODD, anxiety, and then it goes down the spectrum. In adults, you find that there's a great significance of major depression or dysthymia, bipolar disorder, as I mentioned, anxiety disorder, because they have so much of trauma in their life, post-traumatic stress and panic disorder, and substance use disorder is very common. In adults, the substance use, it's important to note that, in our current environment in South Africa, cannabis has become, from a psychiatric point of view, a massive problem. Obviously, from a social point of view, lots of celebration and jubilation because it's in people's minds legal. It's actually not legal. It's legal for use in your personal capacity, in a quantity of less than 3 grams, and in your private abode. But it's being touted as a treatment. And I have multiple patients of all socioeconomic groups that come to me and say, but we've been told
Dr. Saltukar, can you hear me? Hello? Hello, Dr. Saltukar?
Yeah, can you hear you?
Sorry, man, we lost you there. I think the entire audience lost you there for about a minute. So I think you're back now. I don't see we don't see your presentation anymore, and we've lost you for a minute or so. I don't know if you're able to track back and maybe reshare your presentation. I don't know if there's a network signal on your side, a network problem.
I think we've lost Dr. Sadukar. Yeah, it's very, very poor. The audio is very poor, and we can't see your screen anymore.
Okay, I'm going to just switch
There we go.
over.
Yeah,
Is
we
that
see
okay?
it now. Yeah, now we can see you and we can hear you. Thank you. Okay.
Okay, now at what point did you lose? I mean,
we lost you when you were just getting into the number of people you were seeing on cannabis as a treatment.
Okay. All right, so I'll just carry on from there. I think the bottom line with cannabis is it is not a form of treatment for ADHD. And if anyone tells you that it is at this point in time at the level of research that's been done, it is false, it's wrong, and it should not be given to adults or children who have ADHD. I want to say a little bit about cocaine, purely because cocaine increases the dopamine faster than any other drug of abuse. And in ADHD, dopamine deficiency is the problem. So people with ADHD are more likely to abuse cocaine because they feel better than someone who doesn't have ADHD. So something to look out for. I'm going to have to go a bit quickly because we're running out of time. Some of the investigations, when you're investigating a child particularly, it's important to do a full blood count and iron studies because anemia can mimic certain symptoms of ADHD, thyroid functions. So hyper or hypothyroid in children can also mimic some symptoms. And EEG is an important study because you can get the odd occasion where you get absence seizures and you have 20, 30 seizures within a period of time where they zone in, zone out, and it looks like they have problems with concentration. And obviously in the older kids and adolescents and adults, you have to do urine drug screens on these patients. So just in terms of management, it's a biopsychosocial approach to treatment. It's multidisciplinary and holistic. And mismanagement in early childhood, as I mentioned earlier, is disaster because they miss the fundamentals. And usually the mismanagement is due to people believing it's a childhood disorder and it's only for school and so on. So there's a poor understanding of the link between thinking, feeling, and acting. So the general principles in management is that the lifelong condition starts at birth. It's a constant state, it evolves over the ages. You have to identify focus, be aware of comorbidities, and you've got to have a hierarchy of treatment, which we'll try and get through very quickly. Okay, so biologically, we have the stimulants and the non-stimulants in terms of medication. The stimulants at this point, for many years, we've just had methylphenidate. We now have dexamphetamine, which has been available overseas for over 10, 15 years. We've just received it now. And the non-stimulants are things like atomoxetine, certain antidepressants, modafinil, and some alpha-2 agonists. I'm going to say a little bit about Ritalin because obviously that's the one that's most commonly prescribed. It's a predominantly dopaminergic effect, so it increases dopamine in the cortical striatal pathway. It's very effective for attention and hyperactivity. It has pretty much an immediate effect, so you will know within days whether it's going to be a good thing or a bad thing. It requires often a dose titration based on effect and side effect. And in South Africa, we've got the immediate release, the long-acting, and the controlled release formulations. And dexamphetamine, which is newly released in South Africa, which has been around for a long time, and often is the first line in many countries, not in South Africa. Lisdexamphetamine is the long-acting or the prodrug, which is metabolized to dexamphetamine after ingestion. And the immediate release dexamphetamine is also now available. And this works on the dopamine and norepinephrine receptors and is currently approved in South Africa, the lisdexamphetamine, for children 13 years and older because of its long-acting formulation. It has a 14-hour half-life and it takes about 2 hours to kick in. So often if you have to prescribe this for somebody, you have to explain to them they've got to take it for a period of 2 hours earlier than they need it to kick in, and it must remember that it lasts. So it's preferable to take quite early in the mornings. Atomoxetine is the non-stimulant, which is most often prescribed for ADHD where there are problems with stimulants, works via norepinephrine receptors predominantly, more effective for the inattentive type, so not much activity on the hyperactivity and impulsivity or behavioral problems. It is an option if the stimulants cannot be tolerated. It can be used in combination with a stimulant in treatment-resistant cases or difficult cases or comorbid cases in patients who have anxiety as well as ADHD. And it works quite well in adults who don't tolerate stimulants. It's important to understand dosing and timing in terms of your medication. ADHD, as I said, does not end with the school bell. children need to learn academic and life lessons, not just schoolwork. They need to control symptoms throughout the day. So your treatment has got to cover them for all the waking hours, or as many of the waking hours as possible. Remember, methylphenidate has a bit of a come down effect when wearing off. So often if you have to combine treatments, you've got to kind of work out what time the person feels it kicking in and what time it's wearing off before you can top up. You may have to often use different preparations of immediate release, long-acting and slow release. And in the US, the principle of dosing to maximum tolerability is a bit aggressive, but actually they are correct. The early intervention and appropriate treatment means a more profound long-term outcome. They may require higher doses to address the impulsivity and behavioral component. So the inattention concentration is the part that settles first. And that's usually what the teachers are happy about. But then you need to increase the dose to get to the hyperactivity and the behavioral parts. Dexamphetamine is an extremely effective drug. It appears better with anxiety and mood comorbidities, works extremely well with adults. There's a potential for abuse with both, so be aware of it. Ritalin has been crushed and snorted. Dexamphetamine has been crushed and snorted. But this is a problem of substance use, not a problem of ADHD. And remember, with the dexamphetamine, it has a mood effect. So in patients who have an underlying mood disorder, one has to be wary of switching from into a manic state. Comorbidity, substance use disorders are very important, so you have to detox before you start treatment. Anxiety disorders, you can treat simultaneously with ADHD. Mood disorders, similarly to anxiety disorders, can be treated simultaneously. And the conduct disorder, ODD, oppositional defiant disorder, require a combination, multidisciplinary approach of psychologists, psychiatrists, occupational therapists, and so on. And then the psychosocial approach of educational psychologists, occupational therapy, managing the environment, feedback from school and home, and therapy for self-esteem issues. As I said, that is a massive problem. In adults, life coaching is something we can look at once you've managed the condition, because they need micromanaging on a day-to-day basis. There's a link between physical activity and sport because of the cerebellar function link with the ADHD, which is an interesting and fascinating topic, which we don't have time for today. So to summarize, this is a common disorder that can be diagnosed at various stages of a person's life, and the treatment is effective at whatever stage. So it doesn't mean that if you're not diagnosed at childhood, it's too late. They have a good response to appropriate treatment. It can be a life-changing treatment in adults. It's a condition you're often born with and you die with it, constantly 24/7, 365, it's there. It requires comprehensive assessment and treatment in childhood. You don't outgrow the condition. Comorbidity is the rule. And for me, the most important thing and the most devastating thing about this is early detection and appropriate intervention can change the trajectory of a young person's life immeasurably. And that really is the take-home message in ADHD. So I'm going to stop there. I've got other slides which, if people are interested, I'm happy to share, case presentations and more details on the drugs. But I think in terms of time, I'm going to stop here. So thank you for your attention. And if there's any questions, I'm happy to answer.
Thank you so much, Jazakallah, Dr. Sarduka. So the chat is open for questions. Let me just start with one from myself, Dr. Sarduka. So you mentioned that treatment needs to cover the educational setting as well as the general life setting. This begs the question: is that do patients need to be on continuous treatment, or is there some such thing as a treatment holiday or a treatment break? So, for example, do you give treatment for a period during maybe the school term, take it off when they're on holiday? Are there any benefits to that type of approach? Does the treatment, for example, hinder the creative side or something else which would benefit from a drug holiday? Is that concept sensible, or is it a nonsense concept?
So I think, if you look, we're talking about the condition as a clinical disorder. So if you look at the neurophysiology of human brain development, and you try and understand how attention and concentration and the ability to learn has an impact on just about everything we do, then this concept of drug holiday is nonsensical. It has no basis in science, because creativity is derived. This drug does not reduce creativity. I think one of the reasons why people think it does is because when children take the drug, they become very quiet and they lose that, what parents think is a zest or vivacity vivacious nature. That is not creativity. That is the ADHD. And because they become accustomed to it, they think, oh, my child is different, the personality is changing. The creativity will increase if you have more focus and more a more structured brain function. Because creativity is a function of the right brain, as is structured thinking a function of the left brain. So I think, in my opinion, and I'm sure people have other opinions, I think that the treatment of ADHD should be 365 days a year. There is a case to be made if they have side effects to maybe use lower doses during school holidays and so on, but I don't think drug holidays are indicated. And it doesn't make logical sense because it means that there's no learning happening. If you're going to take a kid on holiday and say, okay, I'm going to teach you how to go surfing today, and they're not on their medication, they're not going to be able to focus and concentrate on what the guy's trying to teach them, so it doesn't make any sense.
Okay, we've got some questions from the audience. So one of the questions, I mean, it's not sort of about ADHD, it's about your comments around cannabis. The wants to know, does this just involve CBD or THC, or is it all of them? So obviously that they're differentiating between the CBD and the THC component of cannabis, which obviously now are marketed separately and are sold in sort of separate preparations. So the person is asking that question, and then maybe I can put in another question so you can answer both at the same time. The second one is, what would be the best drug to prescribe for someone who struggles with concentration and has not been diagnosed with ADHD or any other disorder, and how long would one prescribe it? So that comes to your point of cosmetic psychiatry.
So the first thing about cannabis in terms of THC and CBD, I spoke about cannabis in the context of it being touted as a treatment for ADHD. Neither CBD nor THC are proven to be treatments for ADHD. Yes, they may address certain symptoms. One of the symptoms of ADHD is sleep phase delay. So lots of people are using CBD, which is quite a benign component of the cannabis plant to help kids sleep. But we have melatonin, which is a much better and well-researched and better option available pharmaceutically. It's been researched in laboratories. So at this point in time, there's not enough data to suggest that CBD can be used in ADHD. So I don't know if the question is about general CBD and THC or just in ADHD, but because we're talking about ADHD, the answer to the question is no. I don't recommend that anybody uses any form of the cannabis plant in children or adults with ADHD, unless they've tried everything else and nothing else works, which is, I've been in practice for 23 years. That doesn't exist. If you treat something properly, if you diagnose it properly, there will be an appropriate treatment. Oh, and the second point about using stimulants as cosmetic neurology, you can't just say to, if somebody comes to you and say, I can't concentrate and I want to take something for concentration, because it's a debate currently in the scientific fraternity. I think you have to make your own call in terms of what is your belief system in terms of treating somebody who doesn't have a disorder, but you're enhancing the capability. So if you want to give it and you're happy to give it to somebody to help them concentrate through whether it's examination or their thesis or whatever, just be aware that there are certain issues. So stimulants can cause insomnia, stimulants can cause appetite suppression, stimulants can cause anxiety and agitation. So as long as it doesn't cause too much of a side effect, and if you're happy personally giving it to them, it has to be, remember, it's a Schedule 6 drug. You can't just hand it out willy-nilly. There's a specific prescription protocol for it. You can't give more than a certain amount in a month and so on. And there's, remember, significant amount of abuse out there in terms of people who are drug addicts or dependent type personalities who crush it and snort it. There are many mums out there who are taking their kids Ritalin to lose weight because of appetite suppression. So you've got to be aware of all these other things that are happening before you just decide to prescribe it. I think if you are going to give it to someone, give them small amounts for short periods and make sure you check in that they're not having side effects.
So I'm just going to do one more question because there's quite a lot of questions, and maybe Dr. Saldekar he's also has access to the chat. Maybe he can answer some of those questions on the chat later on, if that's okay with you, Dr. Saldekar. So the last question is from a person who's been working at a drug rehab facility and says that being prescribed Ritalin concert at a young age is a precursor to stimulant addiction as an adult. Is there a real correlation? So obviously from your presentation, you should be, it's the other way around.
Exactly. It's the other way around. Undiagnosed, untreated ADHD, when they get exposure to some kind of stimulant which increases their dopamine, suddenly they get a quiet in their mind which they've never had before. So their likelihood of becoming dependent on that is much greater than someone who may not have ADHD. So that is a fallacy. Ritalin and dexamphetamine and so on has been touted in the lay press as gateway drugs. It's actually the opposite. We see a large amount of substance use in undiagnosed ADHD adolescents, teenagers, and adults. But the moment you treat it, their risk or their recovery from addiction is a lot better. So there are many occasions where I've had to treat patients who have alcohol dependency, cannabis dependency, cocaine overuse, and treat the ADHD, and their recovery rate from the addiction is so much better than if you don't.
Okay, Jazakallah. Thank you so much, Dr. Saldekar. There are lots of questions on the chat. I don't know if you don't mind indulging us maybe over the coming minutes while we're preparing for the next talk with addressing some of those questions, if it's possible. I think we won't have time to go through each of those questions individually. I just want to remind attendees that coming up pretty soon later this year is the Islamic Medical Association Convention, which will be hosted in Johannesburg. And we're looking forward to having a broad and engaging program, both on an academic side with significant Islamic content, as well as obviously a social side where you'll be able to meet many of your colleagues and interact with them at multiple levels. So we invite each one of you to attend that event, which will be in September this year, inshallah. We're looking at that long weekend in September. So please bookmark that date, save the date, and we look forward to see you, inshallah. There'll be much more information in the coming weeks and months about speakers as well as about the program. So we look forward to seeing you there. Our next speaker is, just before I move on to the next speaker, just to mention that today's program was sponsored by Takida and Asino. So thank you so much for that sponsorship. Without sponsorships like these, we would find it difficult to keep the organization going, and obviously it allows us to purchase and use this platform. So we're going to move on to our next speaker. Our next speaker is Tasneem Abrahams. Tasneem grew up in the Cape Flats and graduated from UCT in 2002 and is currently living in Johannesburg with a husband and 4 kids. She is currently practicing as an OT in private practice, online and in person, from Your Space for Wellness in Cape Park, Johannesburg, and is in the board of directors for Josie for Autism. She strives to be a neurodiversity ally, providing education and awareness, support, therapy, and coaching to adults and teens who struggle with executive functioning and emotional and sensory regulation, with a special interest in ADHD. She uses the strength-based, client-centered, and evidence-based approach to therapy and coaching, empowering clients to develop self-awareness of personal strengths and underlying challenges, understanding how they unconsciously respond to the environment, and understand others, be more compassionate, and improve their relationships. We welcome Tasneem, and she was going to talk on the role of OT in ADHD management. Assalamu alaikum wa rahmatullahi wa barakatuh, and welcome, Tasneem.
Wa alaikum salam. Sorry, I forgot to unmute myself. Wa alaikum salam. Thank you so much for having me. I was really excited to have the opportunity to talk about the role of OT in ADHD management. Unfortunately, in South Africa, occupational therapy is not as widely understood and utilized as it is in the developing countries. So this is a topic I'm really passionate about because I am very passionate about my profession as well. So I really hope that you will gain some value out of it. Thank you so much to Dr. Salduka for his very informative presentation. There were a lot of points that he raised that I kind of took notes furiously, and it might force me to actually go off of the order of my slides, because there were some things that I think he said that were really important relating to some of the things I'm going to be talking about today. But essentially, you know, as you heard in his presentation, attention deficit hyperactivity disorder is a neurodevelopmental disorder. It does fall under the umbrella of neurodiversity, and some of the other conditions that fall under that same umbrella are like dyslexia, dyspraxia, autism, dyscalculia, Tourette's, among others. So often you'll find that there are a lot of signs and symptoms that are mentioned in the ADHD diagnostic criteria, which also overlaps often with autism. And there is quite a large prevalence of individuals who have both ADHD and autism, and that in itself can also present with a lot of complications. But essentially, you know, as Dr. Salduka said, in the management of ADHD, it's very important to take a comprehensive and multidisciplinary approach, because the needs of ADHD individuals are very diverse. And so what I want to focus on this evening is more on what the role of OT is in supporting these individuals to promote functional outcomes. So I'm going to be exploring a little bit more deeper into the functional impact of ADHD on quality of life, and then look at some of the various strategies, intervention strategies that are employed by OTs in the management of ADHD, and in particular how OT can collaborate with other professionals to enhance the effectiveness of ADHD medication. So I think it's important to recognize and understand the very wide-ranging impact to develop really effective interventions and support systems because you know, we often tend to, as Dr. Salduka said, you know, that like we tend to think of ADHD as mainly a childhood disorder, and we tend to focus it around the academic performance issues. And, you know, typically academic performance would look like difficulty paying attention in the classroom, forgetfulness, poor organizational skills, difficulty with retaining information because of the poor working memory, struggling with following instructions and completing tasks. And you know, just saying those things, you can almost picture this little kid who is not listening to the teacher in class, who's not following instructions, because often like a teacher would give multi-step instructions and they maybe only heard the first one or two and don't continue with the rest. And so it comes across as behavioral problems, and that's how they usually are picked up. And I'm so glad that, you know, Dr. Salduka mentioned the issue where in women and girls, the inattentive type is the most predominant type, which often leads to them not being picked up because they tend to be the quiet ones, the dreamy ones, not causing any problems or disruptions. And so often when we say we try to be neurodiversity allies, it's about recognizing how the neurodiverse brain operates differently. And it's the classic case of a round peg in a square hole, that oftentimes the difficulties they experience is because socially they're not fitting into the way they are expected to fit in. You know, many people also advocate for the fact that while there are many difficulties with an ADHD brain, there are also positives to it. So, you know, the creativity, the being ideas people, those are all things that if the negative impacts are managed correctly, the individual can actually be a really successful person. There's actually a movie that was released recently, I think on Amazon, called The Disruptors, where they interview a number of celebrities or successful people in the various industries who have ADHD. And while they've been successful because they've managed to leverage some of the positive aspects of a neurodiverse brain, they also speak very openly about the very real struggles they've had. In work and productivity, you know, things like not meeting deadlines because of poor time management, struggling with organizing tasks and attention to detail, losing things, often coming late to work. So I have a client currently, for example, who, and somebody asked in the chat about the impact of, moving to remote working, so social economic standard situation that the person finds them in, the impact of COVID-19. I have a client currently who is now doing in a remote working position, and she's currently engaged in a poor work performance formal incapacity hearing process. And a lot of the difficulties, she's recently diagnosed with ADHD and anxiety and depression. And a lot of the difficulties she's having with poor work performance is because working remote alone from her flat, she's struggling with the stimulation needed to initiate tasks, to be productive, to be on time, to respond to texts, and to manage multiple activities at the same time. And a lot of that is because of the impact of her ADHD brain. Now, I wanted to just show you a little video clip of a man called Tim Urban, who speaks. It's just a short extract from his talk, and I would encourage you to go and watch the whole one on YouTube. It's really funny. He talks about, the mind of a master procrastinator. But I just thought that this little clip kind of illustrates in really very real functional terms what the impact can be on somebody with ADHD. And we think of it as procrastination. Everybody procrastinates. And as Dr. Salduka said, we all struggle with attention difficulty sometimes and various signs and symptoms of ADHD. But people with ADHD take procrastination to a whole other level. A lot of that has got to do with requiring dopamine in order to initiate tasks and complete tasks. And a lot of that also has to do with the ability to sustain attention and the need for that dopamine hit. So I'm just going to play the video quickly.
Now, when a normal student writes a paper, they might spread the work out a little like this. So, you get started maybe a little slowly, but you get enough done in the first week that with some heavier days later on, everything gets done and things stay civil. And I would want to do that like that. That would be the plan. I would have it all ready to go, but then actually the paper would come along, and then I would kind of do this. And that would happen every single paper. But then came my 90-page senior thesis, a paper you're supposed to spend a year on. I knew for a paper like that, my normal workflow was not an option. It was way too big a project. So I planned things out, and I decided it kind of had to go something like this. This is how the year would go. So I'd start off light, and I'd bump it up in the middle months. And then at the end, I would kick it up into high gear, just like a little staircase. How hard could it be? Just walk up the stairs. No big deal, right? But then, funniest thing happened. Those first few months, they came and went, and I couldn't quite do stuff. So we had an awesome new revised plan. But then those middle months actually went by, and I didn't really write words. And so we were here. And then 2 months turned into 1 month, which turned into 2 weeks. And one day I woke up with 3 days until the deadline, still not having written a word. And so I did the only thing I could. I wrote 90 pages over 72 hours, pulling not 1, but 2 all-nighters. Humans are not supposed to pull 2 all-nighters. Sprinted across campus, dove in slow motion, and got it in just at the deadline. I thought that was the end of everything. But a week later, I get a call. And it's the school. And they say, "Is this Tim Urban?" And I say, "Yeah." And they say, "We need to talk about your thesis." And I say, "Okay." And they say, "It's the best one we've ever seen." That did not happen. It was a very, very bad thesis. I just wanted to enjoy that one moment when all of you thought, "This guy is amazing." No, it was very, very bad.
Okay, so that is just, a very for people with ADHD, they will watch that and they will relate so much to it and think this is just how everything goes in my life. But of course, you know, ADHD doesn't only affect school or work. It also affects activities of daily living, which is something that is often overlooked. And this is exactly what Dr. Siltuk was saying, is that you can't only think of, oh, we need to fix this problem of behavior in school, or we need to fix this problem of behavior in university, because the management needs to impact across the different areas of life. Now, in occupational therapy, we distinguish between activities of daily living and instrumental activities of daily living. ADLs are basic self-care activities that you need to you need to be able to do to independently care for yourself, like, and meet your fundamental personal needs, like your personal hygiene and eating, going to the toilet, and so on. Whereas instrumental activities of daily living are more complex activities that are necessary to live independently within a community and to engage in daily life beyond your basic self-care. So these activities require higher level cognitive and organizational skills. And these are things like shopping, managing finances, housekeeping. So these activities really are essential for maintaining your health and well-being and independence and having a quality of life. And so having ADHD can negatively impact this. And this is where you end up having a really chaotic life, poor finances. So for example, individuals with ADHD might struggle with organizing and initiating self-care routines. And this can lead to difficulties in maintaining consistent personal hygiene, or you know, sticking with going to the gym, or keeping healthy, or eating. I, for example, have a client who one of his goals right now is literally to have breakfast every morning. That's how simple his functional goal is right now. And a lot of the reasons why he can't is because he struggles with organization, prioritizing, task initiation. And so this impacts on things like housekeeping routines, home maintenance tasks, and can often result in cluttered or disorganized living spaces. ADHD-related impulsivity and inattention can also affect mealtime behaviors, such as difficulty sitting still, rushing through meals, or being easily distracted during eating. It's very common for ADHDers to completely forget to eat entirely. They'll go through a whole day and just they forgot to eat because they were so hyper-focused on what they were doing. They may also struggle with planning and organizing meals, following recipes, managing time effectively in the kitchen. They might find that, you know, struggling with multi-step tasks because of working memory, or they might get distracted with something, or just thinking of the fact that you need to plan ahead to know that if you are going to make X, Y, and Z meal, when you go to the shop, you need to remember or plan ahead that you need to make a shopping list to make sure you have those ingredients. And those are the kinds of things that they would tend to struggle with on a day-to-day basis. Inattention and impulsivity can also influence financial decision-making, which can lead to impulsive purchases, difficulties budgeting, and challenges in managing finances effectively. As was mentioned, dopamine is a huge aspect of ADHD, and most people can attest to the fact that you get a huge dopamine hit when you buy that, go shopping or go on a shopping spree. And this can often, you know, not being able to manage that effectively can often lead to many ADHD individuals, you know, going into or having real financial strife. Planning and executing shopping trips can also be affected. And then in children, inattention and difficulties with self-monitoring can also contribute to challenges in maintaining continence. So often children with ADHD will just forget to go to the bathroom, or they will have difficulties with timing or timely toileting, especially in the younger age groups. And then what about the ADHD medication they are supposed to take to help them with these symptoms in the first place? Well, often they forget to take it. So they are prescribed medication to help them to be more attentive and to plan and prioritize, but then they forget to take the medication because of the ADHD. So, and this is not only with ADHD medication, that ADHDers often struggle to consistently adhere to any sort of medication schedule, whether that's birth control or your anxiety medication, or antibiotic, and this can impact the effectiveness of treatment and overall health management. It can also have significant impact on social and emotional well-being. So they may have difficulties on controlling their behavior and inhibiting inappropriate responses. So this can result in interrupting others, speaking out of turn, or engaging in impulsive actions, which can often strain social relationships and lead to misunderstanding. And then inattention and distractibility can make it difficult for individuals with ADHD to pick up on social cues. So here's one of the signs and symptoms that overlaps a lot with autism. And this can often lead to misunderstandings in conversations or missing nonverbal signals from others. These challenges can lead to social rejection, teasing, or feelings of exclusion. And this can contribute to a sense of isolation and impact overall self-esteem and well-being. And then also the inattentiveness and difficulties with impulse control can lead to increased frustration when tasks become challenging or require extended effort. So they often struggle with emotional regulation, experiencing heightened emotional reactivity, leading to outbursts of anger, irritability, or mood swings. And then the demands of ADHD symptoms, such as forgetfulness, disorganization, and difficulties with time management can create chronic stress and anxiety. So often, as Dr. Salduka mentioned, one of the anxiety is a common comorbidity of ADHD. And often that's because ADHDers are constantly worrying because they know they have this difficulty, and they're always disappointing people because they forget things or lose things or forget to do things, that it actually leads to constant anxiety and worry about not being late or making mistakes, and that can impact their overall emotional well-being. And the negative experiences related to ADHD symptoms, like the academic underachievement or the social difficulties, or just feelings of being different, can really contribute to a lowered self-esteem and self-worth. And so they may develop negative beliefs about their abilities, where often people with ADHD, many do actually have sometimes often even really high intelligence, but then they have this negative belief about their abilities because of all these other issues. So what is the role of OT in promoting functional outcomes? So currently in South Africa, the interventions for ADHD are mainly focused on how symptom reduction can be achieved. And this is usually with medication or psychological interventions. Now that the awareness of ADHD is growing and more people are becoming late diagnosed, and with the advent of social media and people talking about things that help, things like life coaching and or coaching, executive functioning coaching and occupational therapy are starting to be sought out by individuals, because at the end of the day, that although those things do, just psychological and medication does help, it doesn't really provide guidance on how interventions can be structured to deliver real life benefits beyond the symptom reduction, or how to increase participation, because bearing in mind that symptom reduction alone doesn't always produce improvement in daily function. So just because the medication has helped you have an increased attention, that doesn't always translate into the skill development that is needed in terms of executive functioning or ability to engage in daily occupations. So OT interventions really focus on enhancing the effectiveness of ADHD medication by addressing the functional challenges and promoting the development of skills and strategies that complement the medication treatment. And we do this by conducting thorough assessments to understand strengths, challenges, and specific functional needs related to their ADHD. The assessments may include observation, standardized assessments, interviews, and collaboration with other professionals. And by gaining a holistic understanding of the individual's abilities and limitations, we can then develop targeted intervention plans. We work very collaboratively with individuals to teach and reinforce skills needed to manage daily activities effectively. And we do this through structured activities and therapeutic exercises. We help individuals develop strategies, practice the skills, and build confidence using different modalities like role play, simulated activities, visual aids, and technology-based tools to facilitate skills development. We also collaborate with educational professionals, parents, and caregivers to ensure consistency and support across different settings. So, for example, ADHD, as was said, doesn't only exist in school. The problems also exist in the home and in the community. So we provide recommendations and support for modifying environments, adapting tasks, and implementing strategies to promote success and functional independence. And I think this is one of the areas that is really one of the cornerstones of occupational therapy in terms of our holistic view. We use models like the person environment occupational performance model. We don't only look at the individual as central to what is wrong in what is problematic in their life. We look at them in conjunction with the environment, the personal factors. The World Health Organization, is pushing for the use of the International Classification of Function as a universal language across the world and across all professions and across all sectors. And occupational therapy really is at its core what the ICF is trying to promote. We have our body functions and structures, which is your brain and your brain makeup and the skills like your attention and all of those things. But then key to health and well-being is also activities and participation, which is impacted by your social environment and impacted by your personal factors like your age, your religion, your culture, all of those things. And those are influence kind of the occupations that are required of you. Like was said at the beginning, as a Muslim, for example, there are certain roles and activities that is expected of you. And so when looking at treatment, OTs really look at what is important to the person, what is meaningful occupation to the individual, and how does the issues they're having caused by ADHD or any other diagnosis impact their ability to actually engage in those meaningful occupations. So the focus of OT is really enhancing the individual skills, independence, and overall quality of life by addressing specific challenges related to attention, self-regulation, and social participation. Now, there are just some examples of the OT interventions typically used for ADHD. We look at supporting fine motor skills in children, as Dr. Silbuka said, often clumsiness and difficulties with motor skills is prevalent in children. So occupational therapists typically help in assisting the child to develop those kind of skills. Modifying the environment and classroom tasks are one of the things that I mentioned. Providing caregiver and caregiver training. So oftentimes what happens is at school, the child will receive occupational therapy or they'll be on medication, but what about in the home, and how is the parent or the caregiver being educated or assisted to know how to actually manage or empower the child in the home to also continually develop those skills. Supporting sensory processing and executive functions. So I'm just going to touch on each of the different strategies very briefly. So sensory profiling and understanding the sensory brain. Our brains receives and processes sensory information all day, every day. And we all go through varying levels of sensory arousal throughout the day, where the key is to learn to regulate the intensity and frequency. And when our brain receives too much sensory input for us to handle, the fight, flight, or freeze response can be triggered. And when you frequently spend a lot of time in those stages 3 to 5, where you have either overload or burnout or out of control, it can affect your executive functions like sustained attention, task initiation, planning, and emotional regulation. And now if you think about it, if you are an individual with ADHD who already has problems with sustained attention and task initiation and planning and all of those things, and you are also operating in a space where your brain is overloaded, it then further impacts or further causes that to be a problem. So it's a really important approach as occupational therapists, where we help individuals understand what their unique sensory profile is, so that they can understand how their occupational environments that they need to engage in the activities are contributing to their sensory processing levels. And this can be a very valuable tool for stress management and self-regulation. And a very important, by having that self-awareness, you know when you are moving into level 3 and learn which sensory tools you can use to prevent yourself from moving to shutdown, or which sensory tools will help you to stay or get into level 1 and 2 where you can do your best work. It also then helps working closely with, say, the prescribing physician to understand when does the individual need to do deep focus work, or when does this individual need to be at their best brain-based behavior, so that we can look at how the medications, when it works at its best and in relation to the task that's most important. So that is one of the ways that we look at, as OTs, we help an individual recognize when they are in the calm alert state, moving into over alert, and what activities and behaviors will support self-regulation back to a calm alert state. So that might look like in kids swinging and bouncing on the therapy balls. People always say, OTs who work with children, oh, you just play all day. But I promise you, when we are playing with the children, it's not just playing for the sake of play. It's clinical reasoning that we look to actually, analyze what activities will best fit. And then with adults and teenagers, there are sensory snacks, sensory diets, and sensory economics that can be applied to promote sensory processing and integration. Then, of course, as was mentioned, the evidence and the research shows that physical activity can really be beneficial to managing ADHD. But again, you can't just say exercise for the sake of exercise, because what exercise works for one doesn't necessarily work for the others. So I always, as a baseline, we use sensory profiling as a baseline, because understanding your sensory profile tells you what type of physical activity. So for one individual, doing yoga might be extremely beneficial, but for another individual, going running or swimming might be better because it fits with their sensory profile. And then in kids, of course, it's the gross motor skills. Not only does it help with their motor skills, but it also is good for the dopamine hit. It's good for just overall ADHD management. Another very important thing is the use of assistive technology and tools. Unfortunately, occupational therapists in South Africa, we do tend to be a little bit behind in the curve with this, but it's something that is important for us to almost get with the program in terms of knowing what assistive technology tools and applications are out there. But we can use this to help the individual, learn how to organize their time. These can be things like reminder apps, digital calendars, task management software, and helping an individual identify which types of technology will actually assist them. As I mentioned, environmental modifications are a really critical part of an occupational therapy intervention. We would usually assess an individual's home, school, or work environment, depending on which environment it is that they are struggling to perform in their activities. And then we recommend modifications that can reduce distractions or enhance organization. So these are things like, structured routines, minimizing sensory overload. I give you a practical example of with my daughter, where people don't believe me when I say this, but having done a sensory profile on her and just making simple changes to how her room is organized. She's extremely untidy, extremely messy, extremely disorganized, but making simple changes to how her room is set up, putting certain supports in her room has made a massive difference. She's still untidy and still messy and disorganized, but it's more controlled now because of the way that we've rearranged her room. And then, of course, there's education and support, which I've mentioned before. Now, the key thing is that collaboration is key, right? So no profession is an island. We have to operate together. And it's so important that, OTs work hand in hand with the prescribing physician, together with the psychologist, if the psychologist is required for psychological intervention, and with the school and the parents, all hand in hand. It's also important to note the roles of OT and ADHD coaches may overlap to a large extent, and there can be collaboration between the two. So some OTs may incorporate coaching techniques within their practice, particularly when addressing specific challenges related to ADHD, but individuals may also benefit from a combination of OT and coaching interventions. So the key difference is really that OTs are licensed healthcare professionals with specialized education in assessing and addressing various aspects of human occupation, including physical, cognitive, and psychosocial components. So we do have a broader scope of practice that can address a wide range of functional areas beyond the ADHD management. So with a high comorbidity of ADHD with depression and anxiety, and also having an understanding of activity analysis, that is when OT might come in and work hand in hand with an ADHD coach, where an individual needs more one-on-one monitoring, where they need more accountability on day-to-day tasks and things like that. So I just want to read this quote by Dr. Edward Hallowell. He is a psychiatrist who has ADHD himself, and he says that a person with ADHD has the power of a Ferrari engine, but with bicycle strength brakes. It's the mismatch of engine power to braking capability that causes problems. Strengthening one's brakes is the name of the game. And that is what occupational therapists really strive to do, is to almost be the one that you bring your car in for a service and give a full once over of the brakes, and make sure that the person is able to self-regulate well enough to be able to cope with day-to-day life despite their difficulties. Yeah, that's about it. I just wanted to also mention one other thing that is really important. You know, right at the beginning, Dr. Salduka said that, you know, who here struggles with attention, who here struggles with impulsivity, we all have some levels of that. And one of the key things, actually, I don't know if I skipped the slide on executive functioning, might have gone past it too quickly. Yes. One of the things with executive functioning, with ADHD, is to notice that all people with all individuals with ADHD have executive functioning difficult challenges, this executive function dysfunction, but not everyone with executive dysfunction has ADHD. Because executive dysfunction can be caused by many different things. You can go through periods of your life where you have executive dysfunction. That can be because of illness. It can be because of another diagnosis like anxiety, can be because of stress, burnout, grief, many other reasons that you can have executive dysfunction. But one of the key diagnostic criteria of ADHD is that it must be present through the lifespan. It's not something that you develop later on in life. And a very, you know, it's interesting that a lot of the times, because of the high irritability, a lot of the times when children are diagnosed, the parent recognizes a lot of what the doctor tells them in themselves, and that is when they say, but hang on, I think maybe that was me when I was a kid. I had those same problems. Maybe I have ADHD as well. And I think that is a big reason why a lot of adults are being diagnosed now, because their children have been diagnosed, and obviously now they inherited from their parents, and so they become diagnosed. But as an occupational therapist, we take a diagnosis into consideration as a guiding principle, but we don't focus on the diagnosis. What we focus on is what the functional difficulties are that the person is experiencing, and then we hone in on what are the cognitive, physical, social, emotional, underlying difficulties that are causing the functional problems. And executive functioning is one of the main issues with ADHD. And so this is where occupational therapists tend to focus on. We look at how do we improve a person's ability to initiate tasks? How do we improve their goal setting? How do we improve their planning and prioritization? And self-monitoring, so that they can better perform in their day-to-day activities. And that's it.
Jazakallah, thank you so much, Tasneem. I think it was certainly very complimentary to the talk that Dr. Saldukar gave us. I'm going to open the chat once more for some questions and comments. Once more, maybe I can just ask you a question to get going, Tasneem. So, I mean, obviously, as you mentioned, and as Dr. Saldukar mentioned, that there are many people walking around with some aspects of ADHD without necessarily being diagnosable as a dysfunction. The question is, will executive functioning coaching or occupational therapy help those people to achieve specific tasks? So say for example, you have a young kid who's good in school, he's doing everything pretty well, he has some concentration abilities, and he's lots of stuff on his plate. Maybe he's also doing HIVs and he's doing a few other things. And now the parents are thinking, geez, man, maybe he needs just a bit of help to organize himself and organize his thoughts. Is there a role for this type of sort of executive functioning or occupational therapy in optimizing, almost like what Dr. Saltikar was talking about when he talked about cosmetic neurology? Is there a role for this in cosmetic neurology? In sort of people who are otherwise normal in terms of optimizing function or becoming better rather than curing a condition?
Yes, absolutely. So I purposely left the executive functioning slide up there because, as Dr. Saltikar as well said in the beginning, we all struggle with some or more elements of this. I mean, I know I am a classic procrastinator. I struggle with task initiation. And I mentioned my daughter, who has a lot of executive dysfunction, but she doesn't have ADHD. So the issue that what we look at is, when I typically work with a client, we look at what is it that is meaningful to you, that you need and want to do in your life, and how are you struggling? And then we set very specific and functional goals about what it is that they want to achieve. So if, for example, like you mentioned, somebody is struggling with attention and concentration, we look at, okay, diagnosis aside, what is some of the sensory environments that you are studying in, that you are struggling to concentrate? How can we use sensory tools? Because remembering that in the brain, your sensory brain is the first avenue of where information is received. And oftentimes that we'll find that by making simple changes to environment, it can improve your concentration. Then we also look at the thing of planning and prioritizing. If you have a lot of things going on in your life, and it might all be swimming around there in your head, and that can be causing your inability to attend, because you're anxious and worried about all these other things you have to do. Whereas if you can develop systems and processes that you can actually manage your time better. So I would typically use with a client a way to look at time blocking. One of the very first assessments I do is we actually do a time analysis. We use the occupational questionnaire, where we actually record exactly what they do for every half an hour of their day. And then we analyze that based on how well they think they do it, how meaningful it is to them, how they feel, or whether they like it or not, how important it is to them. And we actually look at how do we use calendars, tools, reminders, and actually how to organize their day. And a large part of occupational therapy is grading and graded exposure. So we break down tasks and activities into the simplest components. We analyze what skills it is they need to are required to have, and then we actually grade how much of that skills they need to execute that task, and use simulated activities. A very key aspect of occupational therapy is that we don't just talk through things, we actually do things. Occupation, it's in our name, right? So sometimes I might even go to somebody's home, or go and observe them in the classroom, or I might actually let them come with their assignments, and then we would work through it and say, show me how you approach your assignments, which parts do you get overwhelmed, how can we help you develop the tools in order to work through it in a systematic fashion. And so those are the things that might develop the skills that they need, rather than just taking a pill so that you can concentrate for longer, if that makes sense.
Yes, I think that's very useful. Okay, we got two other or a few other questions. One question is, how effective is medication for the executive function component of ADHD? I suspect that's a question for Dr. Saltikar. I don't know if he's still online. I don't know if you want to.
I am.
Yes.
And the simple answer to the question is yes, it does. The mechanism by which it can help with executive function is we're talking specifically about ADHD. the problem with ADHD is speed and organization of thoughts that affect all other cognitive processes, and the stimulants work by a counterintuitive way of being a stimulant. You expect it to speed up things, but it actually in an ADHD brain slows it down. So by virtue of its primary effect, it does have a knock-on effect on planning and structure and order, because their thoughts are slower. This is particularly more prominent in the dexamphetamine studies, that it improves executive function. There's also obviously many other components. You can't just take a tablet and expect that the executive function is going to get better, but it does help in conjunction with, as Tasneem mentioned, the occupational therapy, the educational psychology, and so on. But the answer to the question is yes, it does.
And another question for Tasneem is: after assessing a child with ADHD, what would you say are good starting points in goal setting, specifically towards adaptations or strategies to apply if a child is at a mainstream school? I think you covered some of this.
Yeah, so I mean, basically what I was saying is that at the end of the day, occupational therapy, we do look at it's very individualized. So there is no generic, oh, this is a good starting point. It needs to be meaningful to the child and what is currently. So usually what I would do, I usually do an occupational self-assessment. So we look at some of the areas that they have difficulties, and then they rate which are the ones that they have the most difficulties, and then pick only the top 3 areas that they feel they want to work the most on. And then we look at that individual area. So let's say it's the fact that they want to be able to remember to hand in their assignments on time, let's say, for example, or they want to remember to do their homework. Let's say that's the thing that they always get into trouble for. That would be what we would focus on. So I try not to make my goals related to specific things like attention or memory, but rather make the goal related to a specific functional goal. And then based on that functional goal and what the executive functions that are affecting that functional goal, that's what we would then target. And then in terms of adaptations or strategies, depending on what it is, it might be a sensory issue, it might be, so for example, my son is extremely movement seeking, and he got into a lot of trouble at the beginning of the year because he would often get up and go to the phone, and all of a sudden a teacher meeting with his teacher, we discussed it, and we came up with a strategy where he would always be the one that must hand out the books in the class or be sent on errands, and the understanding that he needs movement breaks. And he hasn't had a problem since, and his marks has improved, and he's got a good relationship with the teacher now. It doesn't always have to be these big, like elaborate adaptations in class. It can be really simple things like that.
So I think obviously what you're saying is, and I'm sure this is something which runs as a thread through medical care these days, is that you'll have certain principles which are aligned with the evidence which is available about treatment of certain conditions, but you really need to individualize and treat the person in front of you, look at what their particular needs are, both from a therapeutic perspective in terms of non-pharmacological therapies, as well as in terms of their needs in terms of pharmacological therapies and their comorbidities and so on and so on. So I think we sort of come to the end of our session. I'd just like to thank both our speakers, Dr. Saldukar and Tasneem, for excellent and informative presentations. I think the recording of this presentation will be made available for attendees, and your CPD points will be automatically allocated. The presentation was recorded, and a register is automatically generated from the presentation. And obviously it was via pre-registration, so your MP number should be available. If you have any problems or queries around this, you can contact the IMA office, and particularly Kashifa. Once more, a big thank you to Esino and Takida, and thank you to the audience for attending and engaging with us. We look forward to seeing you all at our future webinars, and also hopefully at our conventions. And as I mentioned, later this year in September is a great opportunity to meet everybody in person and to engage with all our different speakers and members. So thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh.